Hi, it's ACR Convergence 2023. I'm Dr. Eric Dein from Atlantic Health, and excited to talk more about some of the great abstracts that we're seeing at the conference today. I'm going to talk about abstract 0495, which is the IZER study, presented by Dr. Plaza from 13 hospitals in Spain on axial spondyloarthritis or spondyloarthritis in general. We know that spondyloarthritis has an overlap with IBD, and this study looked at how much undiagnosed disease there is in our spondyloarthritis patients. This is very relevant to consider, of course, because there is that overlap, but there are real treatment implications, and particularly when we think about medications like the IL-17 class that have a contraindication in IBD. So the study sought to determine the prevalence of undiagnosed inflammatory bowel disease in patients with spondyloarthritis. This included ankylosing spondylitis, both radiographic and non-radiographic, as well as psoriatic arthritis. There were 559 patients included, a mean age just over 50 years old. About half of them were male. 37% radiographic axial spondylitis, 36% had peripheral PSA, so those being the two biggest classes that made up the group. They looked at a screening test for IBD using the fecal calprotectin. And when they looked at it, they found that 47% of patients with psoriatic arthritis had a fecal calprotectin of greater than 80 micrograms per gram versus 53% in axial spondyloarthritis. So about 50% in both groups and just over 50% in the spondyloarthropathy, the axial family. 80% of the radiographic axial spondyloarthritis had a high fecal calprotectin compared to just 20% in the non-radiographic. So radiographic definitely being a risk factor for this higher fecal calprotectin. The mean FC values were also higher in the radiographic AxSpA patients, pretty much 400 compared to about 300 in the non-radiographic and the PSA subgroup. Overall, when they went back to the patients, it looked like 10% of them did have a family history of IBD, and almost 15% had clinical manifestations compatible with IBD, including asthenia in half of those patients, abdominal pain, chronic diarrhea in up to 15%. So they did work up for these patients as appropriate, and they did 189 colonoscopies to look into these patients with a high fecal calprotectin. 167 of these biopsies were for the higher fecal calprotectin, and of these colonoscopies, almost 40% had some pathological finding, mostly aphthous ulcers in 66% of them, superficial ulcers, some erythema, and these were mostly located in the terminal ileum. So based on that, there were a lot of new diagnoses. 23 of the original 559 patients were diagnosed with IBD. This is 4.4%. 22 had a new diagnosis of Crohn's. One had an unclassified IBD. In these 23 patients that had this new diagnosis, 17% had a family history of IBD. 30% had clinical symptoms compatible with IBD. And so I think it's important to think about this in a couple different ways. Certainly, axial spondyloarthritis and IBD have a clear overlap, and in this, about 1 in 25 patients were noticed to have an undiagnosed IBD. Starting with what they did in the study, family history and clinical history are big drivers, are big things that we should start with in the clinic to look at those. But even with that, there were patients that had fecal calprotectin as the potential sign that there might have been some inflammation in their GI tract. So how much of that is of clinical significance? I think we need some more information, but I think it's an important study to, number one, look at that overlap of the disease, put some numbers on the potentially undiagnosed IBD, and the use of fecal calprotectin, which I think could be a great screening tool in some of our patients to look for IBD. So a great abstract over there from the IZER study, and a lot more on this ACR Convergence on Room Now.